Hello, this is Dr. Clark Brittain of Total Health Care for Women. If you suffer from hot flashes, night sweats, fatigue, decreased sex drive, or weight gain, then I would like to invite you to attend a free seminar to learn about the benefits of natural hormone replacement therapy. The beauty of the pellet therapy that we are talking about today, and can you go ahead and pass around some pellets, please, is that these are bioidentical products. And before I go into a lot of detail about it, let me just talk for a minute about menopause and andropause. Andropause is the decline in testosterone production that happens in men over time. And if you think about it, we start out, say, here in puberty with a certain amount of testosterone. It kind of peaks in about the 20s, and then it gradually declines like this over time. Now, you live long enough, you're going to run out of testosterone. And sometimes you run out long before you're ready to give up. Women start in puberty, same kind of thing. They're making estrogen and testosterone. Women make testosterone in fairly large quantities, and it peaks in the 20s and 30s, and then all of a sudden, surgery or menopause, boom, you fall off a cliff. And it literally is like falling off a cliff. Estrogen is important for maintaining bodily functions in the brain, the bones, and the bloodstream. In the brain, concentration, memory, mood, hot flashes, night sweats. In the blood vessels, mucous membranes, and then it helps maintain bone density. Testosterone helps with strength, endurance, muscle mass, mental clarity, bone density, and sexual energy. And if you think about it, in the United States today, one of the really big epidemics of problems for women is osteoporosis. Osteoporosis, or weakening of the bones, begins when estrogen and testosterone production decline. But if you also think about it, men don't get osteoporosis for the most part. So what's the difference? Well, it's testosterone. In the scheme of things, about 25% of the bone strength is related to estrogen. Another 25 or so percent is environmental, hereditary, dietary, and probably 50% is related to testosterone metabolism. The beauty of the pellet therapy that we use is that it puts medicine that is just like what your ovaries and testicles naturally make, puts it underneath the skin so that it's readily available for absorption without the barrier of going through the gut or through the skin. And it exactly mimics what the ovaries and the testicles would normally do in healthy people. So how do you feel? These are some of the things that happen, and some of you can relate to this, I'm sure. Fatigue, mood swings, tension, poor sleep, memory loss, decreased sex drive, depression, hot flashes, night sweats, edginess, and lack of mental clarity. A couple other areas that are involved in estrogen metabolism and estrogen deficiency problems include postpartum depression, which is the most common complication of pregnancy. 20% of all women after delivery have a significant depression, and menstrual migraine. And I'm sure if you haven't, you know someone who has bad menstrual headaches. Well, that, for most people, is an estrogen deficiency. In the natural menstrual cycle, you see this kind of a fluctuation in hormones. And that's separate from this graph that we talked about that's 30 years long. Monthly, monthly, monthly. And with that estrogen withdrawal, some women have enough sensitivity that they get a headache, and that's part of the brain function of estrogen. Is you can use estrogen replacement therapy to help prevent those menstrual migraines. And there's nothing that does it better than pellet therapy. Estrogen stimulates tissues all over the body. I mentioned the brain, the bones, the bloodstream, but mucous membranes like the eyes, the mouth, the vagina, and connective tissue. Our arthritis physician colleagues tell us that their patients who have arthritis who take estrogen replacement therapy hurt less than their patients who don't take estrogen replacement therapy. It might not necessarily change the course of the disease, but the joints are better lubricated and have less pain. If a menopausal woman has an intact uterus, we need to use progesterone because among the things that the estrogen stimulates is the lining of the uterus. And so if you take progesterone, you can counterbalance that and prevent too much stimulation of the lining of the uterus. So for men, how do you feel? Well, testosterone deficiency includes problems with depression, weight gain, sleep loss, joint pain, headaches, fatigue, mental confusion, loss of erectile capability, and loss of muscle mass. And again, for men, it's like this, and it's a real gradual decline. So a lot of guys are going along, and one day they kind of wake up and, crap, I haven't had an erection in a long time. Or, I'm not interested in sex. Or, geez, I'm just beat. They come home, hit the recliner, and they're done for the day. Oral estrogens, and I'll go through with you a couple studies that are really important. If you take a pill, what happens to it? Right, you digest it, okay? So there's saliva, there's digestive enzymes in the saliva, there's digestive enzymes that come from the liver, put into the gut through the gallbladder. Then those medications are metabolized by those enzymes, and then the medicine goes to the target organs. So for estrogens, that means that it's got to be conjugated in order to work. And some really important studies have suggested that as much value as oral estrogen gives you, non-oral estrogen gives you more protection. There was a huge study done in Europe and published in the European Heart Journal in November of 2008. And this came from Denmark, where they have socialized medicine. Everybody who takes hormone replacement therapy is in a registry. And these investigators looked at that registry and followed 724,000 women for 7 years. That's an incredible number of people. For example, the Women's Health Initiative that you may have heard about in this country, where Premarin and Prempro were used for menopausal women, and it caused a huge scare, saying, don't take this estrogen, you'll get breast cancer and die, basically. They studied 30,000 women, and half of them were taking a placebo. So they followed 700,000 women for 7 years. And they made some incredible discoveries. Women who take non-oral estrogen, either on the skin or under the skin, and don't take a synthetic progesterone to protect the lining of the uterus, get a 40% reduction in cardiovascular risk. 40% reduction in cardiovascular risk compared to women who take no estrogen or who take it by mouth. That's incredible. Well, what happens when you take estrogen? Well, you lower your cholesterol, you lower your bad fraction of cholesterol called the LDL, you raise the good fraction of cholesterol called the HDL, and if you take it by mouth, it doesn't touch the triglycerides. Triglycerides are important fatty acids for the development of cell membranes, but they're also an inflammatory component, and if they're at all elevated, they're what lead to plaque formation and hardening of the arteries and coronary artery occlusion. Oral estrogen doesn't lower the triglycerides. Non-oral estrogen does. But that benefit is lost if you're taking a synthetic progesterone. Fascinating stuff. The largest killer of menopausal women is cardiovascular disease. 50% of menopausal women will get cardiovascular disease, compared to breast cancer, which is 1 in 10. Going back to the Women's Health Initiative, which was published in 2002, they used the drug Premarin and the drug Prempro. Premarin plus Provera, which is a synthetic progesterone. And it's interesting in this study that they said that, guys, you know, you take the message that the popular press came up with was, you take this medicine, you're going to get breast cancer, and you might as well forget it. So they quit the study early. Everybody got scared. They quit taking hormone therapy altogether. They continued the study in certain aspects of it. And then some people who understand numbers a little bit better, endocrinology a little bit better, and female anatomy a little bit better, continued to crunch these numbers. And what they found was that the statistics that they were reporting in this study were skewed quite a bit. The women who had an increased risk for breast cancer from the Women's Health Initiative were women who were older when they began hormone replacement therapy and more remote from menopause. Women who began hormone replacement therapy at or near the time of menopause actually did not see an increased risk in breast cancer. And women who took estrogen only and began that estrogen therapy at or near the time of menopause actually saw a slight reduction in breast cancer risk, in addition to seeing a reduction in the risk for colorectal cancer. So if you take that all on balance, taking non-oral estrogen, you can reduce cardiovascular risk by 40%. You can reduce breast cancer risk. I find this stuff kind of fascinating. Again, you can have a natural hormone, but it might not necessarily be bioidentical. And so our goal of therapy with the pellet stuff that we use is to replenish hormones as close to what your body was producing during its metabolic heyday as possible without side effects. And if you think about it, if you give your body what it used to make, how can that be bad for it? This is Brittain's theory, but it's starting to be supported by some pretty good data. And I think that it's actually declining levels of estrogen that are breast cancer promoters. And in part the way we metabolize estrogen. There are several different pathways that estrogen is metabolized in the body. And I think probably those metabolic waste product buildup called quinones that occur in the bloodstream, if they're in a little bit higher ratio to total estrogen, that promotes the breakdown of DNA in breast cells and the promotion of cancer. But if you maintain a higher ratio of estrogen to those metabolic waste products, that eliminates a lot of that risk. You've all heard of patches and creams. Patches are pretty good. It's hard to get enough of the estrogen through the skin to get the kind of blood level that you want to have in order to alleviate a lot of the symptoms of menopause and to achieve levels of hormone replacement therapy that are what you would experience in your reproductive years. Some people react to the adhesive, sometimes they don't stay on, and there's no testosterone patch yet available for women. There's a couple in production and in trials, but there's no testosterone available for women. Does everybody need estrogen? Does everybody need testosterone? Not necessarily. But in menopause, the average woman loses 90% of her estrogen. So 90% of estrogen production comes from the ovary. 50% of the testosterone production comes from the ovary. 50% comes from the adrenal gland. And so what happens with that? Well, some women will continue to make a little bit of estrogen from that testosterone. particularly women who have a few more fat cells here. There's an enzyme in these fat cells called aromatase. And that aromatase converts testosterone to estrogen. So as it turns out, women who are a little heavier have a lesser estrogen deficiency than women who are thinner, but they may have a bigger testosterone deficiency because they're converting testosterone to estrogen. And so when we do this hormone replacement therapy, we're looking at all that stuff. We're looking at these levels to find out what the deficiency is and try to get a pretty close match to what you need for replacement therapy. Estrogen patches, just in the last 2 or 3 weeks, generic estrogen patches doubled in price, and I have no idea what that's all about. And this is for bioidentical patches. In fact, many of the patches that you can get for estrogen replacement therapy use bioidentical estrogen. But if you look at the cost of estrogen therapy and testosterone therapy with the things that are available to use, the pellet therapy that we use is actually cheaper than the topical preparations that you can get. A lot of people like to use compounded creams. And bioidentical in a lot of people's minds means that you're getting some cream to put on your skin. And so what happens with that cream? Well, the pharmacist will take pure estradiol, which is the predominant estrogen for women, and pure testosterone, and put them in separate creams, and have you put it on your skin. Well, you don't just do this, okay? You can't just do that. You actually have to use a part of the body where there's not a lot of hair, so sometimes it's here, sometimes it's the thigh, and you have to put it on like that, or like this, because if you use your fingertips, the fingertips don't really absorb the stuff, and so you're wasting a lot of the medicine. There's a lot of variability from one pharmacy to the next on the concentration of the hormones that are used and the availability of it through the creams that are used to dilute it. So among the things that I do, and the Soto Pele physicians that have been trained around the country by Dr. Tutera, we look at a combination of things in order to try to calculate a level that you need for replenishment therapy that includes physical characteristics, exam findings, laboratory findings, and the symptoms, of course. And we come up with a dosage of replacement therapy that we think is going to work for you, give you that therapy, but we don't just say, okay, see you in 6 months. We do follow-up labs to make sure that, in fact, your body's responding the way we want it to, or that you want it to, really, in order to get the maximum benefit. And that's whether we use creams or patches or gels or sprays or the pellets. But the other thing about the creams and the gels is that they can wash off. You could rub it off onto someone else. I think the bigger things are that the standardization is a problem. And the North American Menopausal Society, which is fairly powerful, but not near as powerful as the pharmaceutical industry, the pharmaceutical industry is taking umbrage with the bioidentical hormone therapy used by compounding pharmacies. Because of the lack of standardization from one pharmacy to the next, they're saying that it's not reliable, you can't count on it, and they're working very diligently to try to ban prescription use of bioidentical creams. Well, we know that testosterone helps build bone through several studies that have been done along the way. If you look at osteoporosis as an example, there's about 1.5 million pathologic fractures in the United States every year, mostly among women. We just don't see a lot of osteoporosis in men. They continue to make testosterone, even though it's declining. They're making a comparatively higher amount of testosterone than women do. And the ratio between men and women is about 10 to 1. So men make about 10 times more testosterone than women do. So we know that testosterone helps build bone. Well, the studies that have actually looked at bone production in menopausal women have found that if you take some oral estrogen, you can anticipate about a 1 to 2% improvement in bone density over time on an annualized basis. Throw in calcium and vitamin D, you get a little bit more. Use topical estrogen through a cream or a patch, and you get 2 to 3% improvement in bone density per year, which is about the same that you get with Fosamax, Actonel, Boniva, Forteo, and all of those bisphosphonates, which don't give you the estrogen benefits. The bisphosphonate therapy is really good, and we use it for women for whom estrogen therapy might be contraindicated, but you don't really get any more improvement of bone density with that than you do with estrogen, plus estrogen can help relieve hot flashes, night sweats, vaginal dryness, and so forth. The studies that have looked at this have shown that if you add testosterone to that therapy, you can improve bone density by 8 to 9% a year. 3 times as much as Fosamax, Actonel, and Boniva. We talked a little bit about cardiac events. This Locagard study from the European Heart Journal, you can go online and look at that. The Women's Health Initiative has been revisited. I mentioned that a little bit. And this is what I was talking about for the improvement in bone density. Dr. Tutera was interested in investigating the effect of his hormone replacement therapy and breast cancer. And he followed 976 women for 10 years and would have expected around 100 cancers. He said maybe 90, and found 1. And again, I think that's in part related to the concentration of metabolic waste products from estrogen and the total estrogen concentration. And if you think about it, who gets the bulk of breast cancer in this country? What age group of women? 50s, 60s? Who's making all the estrogen? What age group? 20 and 30. So it's pretty hard just on the basis of the teleological aspect of it to say estrogen's bad for you. The other thing about this estrogen replacement therapy that's kind of interesting is that if you take comparative women who have been on estrogen replacement therapy and no estrogen replacement therapy and get the same kind of cancer, the women who've been on estrogen replacement therapy have better outcomes of those cancers than women who were not on estrogen replacement therapy. Advantages of the pellet therapy. We put these underneath the skin. Here in the United States, most of us use the fanny because fortunately most of us have a little bit of padding there. So anyway, we need a little bit. You don't need a lot, but you need a little bit. And so we put this pellet stuff underneath the skin, usually here in the buttock. In Europe and Australia, they use the flank a little bit more. It keeps there's 3 forms of estrogen. There's estrone, estradiol, which is the dominant estrogen in the body, and estriol, and it keeps a ratio of those pretty good. It gives you a steady state. We put the pellets in here at 0.0, and you get 4 to 6 months of steady release of estrogen and testosterone therapy before it starts to fall off. That's better than anything else did I do something? Better than anything else that we can offer. You avoid this roller coaster effect like a monthly menstrual cycle. And there's nothing that you have to do. It's got to be put in by a physician because it does involve a fairly large caliber syringe. We usually put a little Novocaine bee sting in the buttock, make a tiny opening with a knife, a 3 millimeter opening, put the pellets in underneath the skin, and then put a special bandage over it. One of the stories I tell my patients in the office is, have you ever had a houseplant that you forgot to water? What happens to it? Kind of does this, right? And then if you recognize it in time and give it a big drink of water, what happens? Nothing. It just sits there. But a few days later, it starts to do this, and the leaves uncrinkle and start to grow again, right? Well, our bodies are like that. Only human bodies are a little bit different than plants. It takes a little bit longer. So if you've been estrogen depleted and have a really stiff, leathery, dry vagina, It's going to take 2 or 3 months for that to get elastic, lubricated, and more sensitive. Same thing with the brain. I had this really interesting patient not too long ago. I told her the same story, about the house plant, you forget to water and all that. And she was sitting on the table. She said, "Doctor, I had just about given up on these pellets. I was pretty sure they weren't working. It was almost 3 months into therapy, and then one morning I woke up and it's just like the fog had lifted."
Dr. Brittain is one of only 6 physicians in Indiana certified to deliver this revolutionary therapy for women and men. We invite you to learn more about the benefits of natural hormone replacement by calling 812-331-9160 or online at hormonetherapyseminar.com.
I hope you'll join us to learn how you can live a more vibrant life.